And then, okay.
But we're not muted either.
Okay, and then they can hear us. Okay. Apparently only staff. Start broadcast. Okay.
The broadcast is now starting. All attendees are in listen-only mode.
Good morning. This is Tracy Plouck with the Ohio Department of Mental Health and Addiction Services. You are joining us for our webinar on the 2014 Mid-Biennium Review and how that relates specifically to our department and the field with which we work. If you are joining us on the webinar, you are automatically muted, and I understand that some folks may be joining us by phone only, and I would ask that you also mute your lines if you've not done so already.
Yeah, she stepped into the office.
And I can hear for certain that some people have not muted their lines, so please do so. Okay. By way of overview, I'm going to touch briefly on some highlights of the governor's overall proposal and then drill down into our system and the reforms that have occurred to date and what we're proposing to do in the mid-biennial review. At the end, I've got a list of some technical corrections and other language improvements that I would want to call to your attention. And at that point, assuming that time permits, we will go forward and field some questions. So generally speaking, the MBR includes 4 pillars. The first one is related to education. And clearly, education is the key to employment and upward mobility, regardless of where you are in our state. And the governor has put significant focus on both K-12 and higher education in this bill. There is quite a bit of tax information included in the bill, and as you may be aware, we are actually opening up testimony in the House Ways and Means Committee later this afternoon at 3 p.m. So I'll speak just a little bit later about the Earned Income Tax Credit because that may be of specific interest to folks in our field. Workforce, including strategies for different state agencies to work together in support of individuals who are looking for employment or looking for the next job. And then also specifically assistance to veterans are included in the bill. There are a few other human services related items, including tobacco cessation funding and some strategies that will be coming out soon, and also enhanced training for the state and for parents, families, developmental disability professionals for services related to autism. Okay. I want to begin now with the MBR items that are specific to our field. And as you may have seen about 2 weeks ago, the governor spoke at some length about the challenges related to mental health and addiction services during the State of the State address. And I've got some excerpts here for you on this slide just to remind you if you saw it or if you hadn't seen it to get some of the context of what he shared that evening. As far as reforms that we've undertaken in the last 3 years, there were many state-funded services and supports affected by the economic upheaval several years ago, including, obviously, our system of mental health and addiction services. And the governor's first budget about 3 years ago increased state spending in the aggregate for mental health for almost 6%. And probably the most significant thing, though, was to effect a change whereby the state would take over the match responsibilities for Medicaid payments for mental health and addiction services. And this really helped to lay the foundation for our ability to move forward with Medicaid expansion, which we were able to do so just this past January. So had we not taken the opportunity to relieve the counties of the match responsibilities, I don't think that it would have been possible on a statewide basis to extend Medicaid benefits in the way that we're doing today. So clearly, though, the biggest, I think, benefit that has occurred within the last 3 years related to our system is one that is continuing to unfold, and that is our ability now to enroll individuals who, in many cases, were living with mental health and addiction needs and without health care. We are now able to enroll many folks into the Medicaid program. The $557 million that's referenced on this slide is the sum of some estimates from Medicaid from last year that in 2015, folks who are known to our system were expected to receive Medicaid benefits, physical health benefits of about $482 million. So that's things like physician visits, pharmacy, hospitalization, et cetera, that previously, if they had access to care, it was through a safety net, largely emergency department or FQHC system. And in addition, we calculated last year that there is approximately $70 million on an annual basis that will be available in the aggregate to the local ADAM boards to redirect to other priorities now that Medicaid is coming in and providing reimbursement for some of the clinical services that previously the boards were responsible to pay. And just to remind you of this analysis, we actually looked at fiscal year 11 claims data in MHAS for individuals with incomes up to the point that Medicaid would cover if we expanded coverage. And we looked at only reimbursement for those services that Medicaid would reimburse. And that total was about $140 million in fiscal year 11. We knew that under no circumstances would every single person who's eligible for Medicaid enroll in Medicaid. And we also knew that there were some circumstances where boards would continue to render clinical services to individuals who might exceed the income ability to enroll in Medicaid, or they might just have a crisis that needs to be addressed. And so we took a 50% assumption on that $140 million, that as Medicaid was fully realized and folks were enrolled in a robust way, there would be $70 million available in the aggregate, again, to redirect to other supports such as housing and prevention and employment supports, et cetera. So that is just sort of a reminder of how we came up with those resources. So we made the case to expand Medicaid about a year ago, and the General Assembly did not expand Medicaid as the budget passed in late June, and instead they appropriated $47.5 million, both in fiscal 14 and in fiscal 15, to support clinical services or other services in our field because Medicaid was not being extended. And as you're all aware, last November, the Controlling Board actually moved to authorize the appropriation authority to expand Medicaid. And now we have an opportunity to take the resources that had been intended at the time that we didn't think Medicaid was going to happen for us, and reprioritize those to hopefully, address other needs. And that's what I'm going to spend most of the time talking about today. We're getting some feedback, so if you could please make sure that you have your phone muted, I would appreciate it. So what we're attempting to do, proposing to do in the MBR is to be more focused on some significant gaps in our collective continuum of care as we work to actually get folks enrolled in Medicaid. And I think that there are some places in the state where it's helpful to actually partner across ADAM board jurisdictions. And I want to be clear here that we are not trying to eliminate boards. I want to be very clear about that. What I'm saying here, though, is that the planning and execution of some services, in some cases, makes more sense if we have a resource that transcends board areas. Maybe it's not something that an individual jurisdiction would need. Let's say a setting that has 10 beds. They wouldn't necessarily need 10 beds every day, but on an ongoing basis, they sure could use 2 or they could use 3. And so this is There are many of these partnerships underway today, and what we're seeking to do is actually identify gaps that we could employ more of this strategy, or we could look at other kinds of approaches that would help specifically in the arena of crisis and housing. So we will propose to be more focused with the use of the $47.5 million, which we're seeing as, absolutely one-time appropriated for 15, unclear whether those resources would remain into the future in light of the fact that we now have the Medicaid expansion. But we want to focus more on statewide prevention efforts. You may be aware we have about $860,000 that's appropriated through our general revenue fund today to support prevention efforts, and an infusion of more than $6 million clearly is a significant augmentation to our existing efforts. We also want to double our GRF commitment to subsidies within some of our licensed community-based settings, and I'll talk more about each of these in just a minute. We also want to work with the boards and with other partners and really actually build on what I feel is a pretty strong foundation of partnership that we've developed in the last few years, and really take that to the next level to focus on where we can meet some continuing needs with respect to crisis services and housing. And then we also want to make a long-term investment in our hospital infrastructure. And you are probably aware we have 6 hospital sites throughout the state that have more than 1,000 beds collectively. And we are operating with an electronic medical record that is quite antiquated at this point. We are proposing to undertake a partnership with the Ohio State University Wexner Medical Center to have that organization host our electronic medical records for our state hospitals. This is a resource that benefits all communities throughout the state, and I think that it's important that we make sure that we have infrastructure that is supporting the highest level of clinical care possible. So we're proposing up to $2 million of the $47.5 be used to move forward with a partnership with Ohio State. Now, I want to be clear here that we do not have a contract that's executed at this point. We're in negotiations, but we are optimistic that hopefully this opportunity can come to fruition. And so this is a commitment that is still tentative at this very moment. And then also I wanted to let you know that while most of this presentation is focused on our operating needs and our plans with respect to our operating budget, we do anticipate that the governor is going to propose $15 million in the community capital bill, or for community projects in the capital bill that's anticipated later this spring. We have $10 million for capital community projects in this current capital biennium, and that was the most that we'd received in 10 years. So we were delighted to have the 10, and now we're having that increase by 50%. This will give us an opportunity to address the infrastructure, the capital needs of both mental health and addiction services. And we're expanded about building out that continuum as we go forward to reflect the broader mission of our new organization. So there's a lot of different pieces here, and I think that partnership and open communication is absolutely essential if we are going to make the most impactful use of these resources in fiscal 15. So I want to take an opportunity now to drill down into some of the objectives that I've highlighted briefly already. Prevention is the first one. We have $6.5 million that is earmarked within the 507 line item for statewide prevention initiatives. And this first slide provides a list of some of the major components of that proposal. $5 million would cover the first 4 bullets on this slide: the statewide youth survey, capacity building for community coalitions, our youth-led network, and then expanding support for evidence-based prevention practices. The other $1.5 million will be used to support some specific providers who are funded primarily or wholly by the Substance Abuse Prevention and Treatment Block Grant. And we've been very open with the fields in planning over the last probably 9 months or so that we are going to be embarking on a cash alignment strategy beginning in July of fiscal 15, whereby we will try to catch up with the amount of the federal grant that is available to our state. And the way that we're doing this is elongating a grant that the former ODAT is typically spent in 4 quarters. We're elongating it over 6 quarters on a one-time basis so that we can become current with our federal awards. This will lead to more predictability of when cash will arrive in the field, and I think that there is widespread agreement that this kind of a fix is necessary. But with that said, we also recognize that for 6 quarters, providers who are funded significantly by SAPT will have some cash management issues to deal with. And this $1.5 million will be used to direct to the prevention providers who are going to be experiencing some of those challenges to kind of mitigate the impact of the cash alignment on their operation. The next topic that I wanted to touch upon was the $7.5 million that we're proposing to double our residential state supplement program. Specifically, what we would like to do is provide this subsidy to additional individuals who are living in licensed settings of 16 beds or less. There are facilities that are licensed by the Ohio Department of Health that have more than 16 beds. And I want to be clear that because we want to focus on the community-based nature of a licensed setting as a priority, we are going to offer the subsidy to individuals who are working with providers and being hosted by providers of 16 or less. We had a legislative study committee that, or it was legislative because it was required of us in the last budget, a study committee that occurred last fall, and we finalized a report in late December that I would encourage you to review if you've not already done so, that had a series of recommendations, and we see this augmentation of the resources as a one response to those recommendations. Just so you know, our current budget, as I said, is $7.5 million of general funds for this subsidy. As of February 20th, there were approximately 1,380 people enrolled in the program. So the benefits from this program that an individual receives varies depending on the amount of income that they have. But generally, clients receive a maximum of $635 a month. And again, you know, it could be less depending on their circumstance. So if you assume that there is a maximum of $635 per client per month, the $7.5 million will allow us to serve about 1,000 more folks. So you will look for more process information from us related to this initiative in the coming days and weeks, but generally speaking, we expect that we'll be able to serve about 1,000 additional individuals. I want to move on now to the gaps related to crisis and housing, and the governor spoke to this at his State of the State address. We have $31.5 million that we are setting aside within this 507 line item to work in consultation with boards and seeking impact from others within the field to identify some strategies that will help us support the overall system transformation as individuals are enrolling in Medicaid, and in many places there's more agility over a period of time with existing dollars. What we want to do is work on, sort of take the hotspot approach that we have employed in the last 2 years, where boards are working with us and in concert with others across their jurisdiction lines to make investments that create an economy of scale or add to the continuum in a way that is, you know, beneficial to those communities. we are not at this juncture saying that there is a one-size-fits-all in what the strategy will be or what kind of projects will be undertaken or how the partnerships might unfold. I think we're going to be having more detailed discussion with the boards and with others in the coming weeks, and so I want to sort of lay out the broad framework today, but we want to make sure that we are investing in services that folks in communities see as a gap today that they are interested in sustaining in the future. So you'll hear more about that from us soon, but just to offer a couple of examples of some hypothetical projects, recovery housing for individuals who are living with addiction is something that many communities are identifying as a priority, and we have community plan information from all of the board areas, and you know, you can see what the different needs are. But just to pick that one out as an example, some of these resources could be made available specifically for recovery housing opportunities in, you know, certain locations in the state. Others might be more of a regional resource. For example, maybe some facility that offers crisis services for young people, or a step-down sort of a housing opportunity for individuals who might be leaving a hospital environment and they still have some pretty intense service needs that may not be able to be met locally, because there might be the only person who has that level of need. And so having some economy of scale where a board could elect to buy bed days on an as-needed basis might be a resource that would be of interest to communities. And so these are just examples, but to kind of, you know, provide a frame for you and what we have been thinking here. And then also, of the $31.5 million, we are setting aside $1.5 million specifically to supplement the women's treatment providers that are affected by the cash alignment process related to SAPT. So I spoke at some length about the prevention providers funded by SAPT a few minutes ago. This is very similar in nature, but treatment providers focused on women. Okay, so going back to the $30 million that would be seen as a regional resource, I have here for your reference the grouping of the counties, and these groupings are currently used in our hotspot collaboratives, and so that's the reason why you know, you see the list arrayed as it is. There is an existing planning relationship that these boards have. Some of the projects that are underway with the hotspots this year are you know, transcending all of the boards in an area, and some of them might be specific to a single board or a couple of boards. And so there's quite a bit of diversity as far as what's underway today. And we would anticipate that there would be some degree of diversity with these dollars as well, based on what different kinds of needs present in a region related to crisis and housing. But this just provides you with some reference related to scale. And then I've walked through the uses of the dollars related to the specific objectives. This is just a visual to show how the $47.5 million breaks down for those of you who might be more visually inclined. Again, I think that this proposal is intended to be a bridge to support the overall system as we move forward into this new environment where more folks have access to a health care payer source, and thus our local planning authorities have some decisions to make related to long-term planning as it relates to where their supports and their financial support would be most impactful. So we see this as a bridge. We are not seeking to alter the Section 340 of the Ohio Revised Code, which speaks to the local planning authority role of the boards. You know, I see this as an opportunity to actually work in a greater partnership with boards in the next year, as well as others. So I want to move on now to some other language improvements that we are offering in the bill. Some of these are temp and some of them are permanent law. If they're temporary law, they are indicated, and if it's permanent, there's a reference to where you can find the specific language in the bill. The first item, though, is related to our partnership with not only the individual communities in Ohio, but also the Ohio Department of Rehabilitation and Correction. And we have identified 5 counties to which the greatest number of DRC inmates return from prison stays. And what we are including in this temporary language is a requirement for these county boards specifically to prioritize the use of funds made available through the state for a short-term basis to assist individuals with clinical services that would be payable by Medicaid when they get their Medicaid card. And I was talking with Jerry Craig from Summit County last night and said, you know, this language is really intended to be a backstop, because as we you know, sit here today, Rehab and Corrections is working with Medicaid to develop and hopefully by next month or so execute a process whereby offenders who are leaving prison will actually have a Medicaid card. So that work is underway, and we anticipate that by the passage of this bill, this language actually will not be necessary. But I think that the goal would be, again, to sort of backstop so that there is a bridge in terms of connecting with the clinical treatment that's necessary so that the person can get a start back in the community with the sorts of mental health and addiction supports that they need clinically, so that they are able to hopefully avoid returning to prison or jail based on an offense that you know, could be avoided if they had the connection with treatment that would be most helpful for them. Again, clinical services that would be billable through Medicaid. We also have changing subjects now, some technical cleanup related to consolidation, where maybe the full name of our new department was not printed in the law as it should have been. So those are non-substantive changes there, but we've got the citations for you. The third language change is related to a request from the Board Association, and that was to provide some additional flexibility for local board appointments. We are changing the criteria that when an individual who is appointed to board is going into the category of someone who is a recipient of a service, we are eliminating the provision that the service has to be publicly funded. And so if you are an individual who is living in recovery from addiction and you sought services with your private sector insurance, you would still be eligible to serve on the board in that specific capacity, just as an example. Moving on, we have some changes related to the indigent driver alcohol treatment funds. And this is a somewhat complicated area of the statute, but we have worked with judges and the Board Association and others to collect information on what would be most helpful for change. And we've got the citation there where you can see the specific detail of what we're seeking. Basically, we want to create some additional flexibility for treatment to be rendered and sort of avoid some of the silo effect of the individual jurisdictions within a county if all the judges are on board with partnership. So that's an example of one of the changes there. We see this as a positive step forward, not only in our collaboration with the judicial system, but also hopefully in obtaining some additional dollars in some communities for treatment that is necessary. We also have some language that we are considering cleanup language related to county probate courts. This language was inadvertently removed some time ago from the code, but it allows one court to charge back costs to adjudicate an individual from another court. So, for example, if Franklin County is adjudicating an individual who is actually a Fairfield County resident, this would allow for the charge back to the appropriate court in the appropriate county. This does not create any costs or charges for the ATOM board in either county, so just want to make sure folks are clear on that. And then also, I spoke at great length about the $47.5 million. We do have temp law that actually itemizes the uses of the dollars that I walked through earlier in this presentation. We have some changes in appropriation levels in the MBR. Specifically, many of you are aware that we have an Office of Support Services that prior to this September did not only pharmacy services for our hospitals and rehab and corrections and outpatient sites, community providers around the state, but also provided the food procurement and warehousing as well as some supplies for the entire prison system. Rehab and Corrections made a decision in this last budget to take a different direction with their procurement of food and sundries, and so we are decreasing our appropriation in our Office of Support Services line to reflect that change. So we closed out that line of business this past September, and we've moved on, but I just wanted to make sure that, you know, folks knew that this wasn't a cut. This was, you know, this is something that had been already planned and executed. We're also seeking an increase to some grant line items to account for some grants that we've received recently, and we've communicated broadly about the SBIRT and the Safe Schools Healthy Students grants. So those are also found in temp law. We are going to have a permanent code section related to problem gambling treatment, and this allows for an endorsement to a chemical dependency counselor's license specific to gambling. This was, I believe, undertaken as a separate bill at one point, and we've rolled this in as part of the MBR. So, you know, there's been discussion underway with the boards, the credentialing boards, for some time about this. We have a technical change regarding our funding of Recovery Requires a Community, which is the program with which we are assisting individuals who are under 60 and living in nursing homes who have mental illness to move into community settings. We have already got transfers underway from Medicaid, but this was a change, technical change that was requested by the Office of Budget Management, so it doesn't have any impact on the program as it is successfully running today. And also we have the temp law that requires the appointment of a coordinator within our prevention team for the Start Talking program. I want to be clear that this coordinator is being hired with existing resources. There are no new dollars that are, you know, set aside to fund this staff position out of the 507 line item or anywhere else where we're managing this out of existing payroll resources. But the governor, as he indicated in his State of the State, feels very strongly that we need to keep the momentum going, and so we will have a coordinator join us soon who is going to be working in concert with folks internally to our department and really the whole field to make sure that we're building on the programs that we introduced this past January in the prevention arena. A couple of other language items that are not within our specific department's purview, but I thought might be of interest to you. The governor's MBR will have nearly $27 million identified and appropriated to the Ohio Department of Health to support a 5-year augmentation for tobacco prevention and cessation programming in our state. There will be more information forthcoming from the Department of Health and the Office of Health Transformation about this. Dr. Hurst, who's our medical director, is involved in those discussions. So he is representing some interests of our field specifically as it relates to these dollars, but they are within the Department of Health. And then also the earned income tax credit changes have the potential to benefit lower income households in Ohio who make the federal earned income tax credit claim, and it's an expansion of benefit to folks in Ohio. I know that our legislative folks internally are working with stakeholder groups who might be specifically interested in this to share some additional information. But if you are interested in the EITC, the tobacco cessation, or anything else that is broader than what I've outlined specifically for our department, you can go to the state's MBR website, which is at transformingohio.gov, transforming.ohio.gov, and you'll see that here on the slide. And then you can find us in all sorts of places on the internet and through applications. So I would encourage you, as this discussion unfolds, to follow closely the dialogue, and I see this as a huge opportunity for us here as we are moving into the second year of the biennium. So that concludes my prepared presentation today. Just so you know, we have 93 folks who are registered for the webinar, and I've got some questions here. Let's see. I'm seeking some assistance on how to actually be able to read them. Okay, I have a question. Tracy, how will the department use the community plans in conjunction with the $30 million? Is this only focused on crisis and housing? And that is, I think, from Elaine Gargas in Lorain County Addis Board. What we are, and we will be meeting with the boards later this week to lay out some process parameters, and we'll be meeting with others as well. We have I think an information briefing that we're lining up with the Ohio Council soon. But what we want to use as a point of departure, looking at, I can't go backwards, looking at the different regions of the state, we want to draw the community plans from those identified counties in those regions. And we've already gathered kind of a high-level summary within the overall umbrella of crisis and housing, which boards have identified, what specific kinds of challenges in these areas. And we want to use that as a point of departure for discussion. So I want to be clear that we will be using other data, we'll be using our knowledge and really the field's knowledge of other challenges that have been brought forth in these two general topic areas within those communities over the last few years into the discussion. I would anticipate an open process where we've got, feedback from, a wide variety of stakeholders in the affected areas. But I think using the information that the local planning authorities have actually gathered and organized and submitted, it makes sense, to really begin the conversation. Is there any way that we can make this bigger?
I'm not actually sure. A couple of questions.
Okay. The next one is, have the programs that will receive their capital grants already been identified? The capital budget, and this is from Joe Gay. Joe, the capital budget will not be introduced probably for a couple of months yet. We thought that it might be introduced this month, but it looks like it may be mid-May or later. And so until we have a budget that is passed and we know that we have the appropriation, we will not be making any final decisions about disposition of those funds. I am delighted that the governor is planning to propose $15 million. I cannot really tell you how delighted I am about this. But that may not be the number that we end up with ultimately. It could be, lower or higher. And so we won't put out any final plans until the passage of the bill. I would anticipate, though, that we will use generally the queuing process that I think was pretty successful last time, as far as as individual projects gather other sources of funds, and ours is enough to really get them over the finish line. We would want to be identifying projects that way so that we know that we're actionable as soon as possible with the dollars. But with that said, there's also last budget we said we just want to focus on housing, and I think that we want to step back now, and we've got AOD-related housing continuum to concept. Also had quite a few requests for residential and other treatment space. We've had requests from communities for some consumer-operated space, and so I would see us as a first step, kind of identifying the parameters as far as the amount of resources that we might want to designate for different categories, or if it's just going to be a straight-up queuing process. We haven't determined that yet, but I would expect you to be seeing more from us, as we get closer to the passage of the bill that way. So if any project out there is listening and hasn't communicated an interest to your board, certainly do that. The board submitted plans, but as always, if something comes up that is a great opportunity that may not have been envisioned when you submitted your capital plan, we're always happy to talk with you and see if there might be something that we could do to assist. Sorry for the long-winded response there. Next question, will the slides be available for download? We will have the information available. The presentation is actually being recorded and will be posted to our website. And so I think we could also put the slides up, as standalone. But I know that we'll be posting the presentation also.
We are having some technical difficulties. My mouse is no longer working.
Okay, we're having some technical difficulties here. Can we use the buttons? No. Okay.
There it is.
Okay, we have the mouse working here. The next question, let's see here. Is there any intention for any changes with the prevention credential as far as endorsements in problem gambling, violence, mental health or wellness, etc.? I do not have personally a response to that at this moment. To my knowledge, there are no changes to credentials that are included in the bill. But if my understanding of that is incorrect, we will communicate that when we post the link for this presentation on the web. But I'm unaware of any piece that we're proposing in the bill that would do that. Let's see. Next question from Jonathan Wiley. Do you have current data related to Medicaid expansion by county, which is a conversion from community-funded care to Medicaid? Jonathan, we have not updated our analysis from what we used in the last budget period a year ago. And as I said earlier, we used FY11 data there. I've had some conversations recently with both boards and providers, though, and I understand that the enrollment process in some areas of the state is not going as quickly as folks would have anticipated. And one thing that I would like to offer within the next couple of weeks is a discussion with some updated data from Medicaid on how the enrollment is going on a county-by-county basis. How many folks have been enrolled, what the queue that is, pending is in each of those counties, because I think that I know actually that they've been working the queue at, through the CDGFS organizations, and so if someone applied on January 1, their wait time might have been pretty significant, but if someone applies today, that queue is, quite a bit smaller in many places, and so the wait time going forward would be less. So I think having some feedback directly related to current status from Medicaid would be really helpful to us as we're thinking about how we can be helpful, to kind of move this along and get as many folks enrolled as soon as possible. All right. The next question. Hi, Tracy. Does this mean only expansion for mental health and addiction services? No scaling down or cutbacks? The question, only expansion. We are not, I'm not exactly sure what you mean by that question. We are not reducing any resources that are currently available, to the field in the aggregate, if that's the question. These dollars, though, the $507, were already appropriated for fiscal 15 by the General Assembly last year because we budgeted on a 2-year basis. And what we're doing is refining our expectations for use in 15 relative to 14. So if that doesn't answer your question, send another question. But I think that's the way that I would read this. Okay. I think that's the last question that we have. So I appreciate your time this morning. We will be offering testimony, as I said, in the House Ways and Means Committee this afternoon, and we will be. We've got actually some detailed spreadsheet information that we'll be making available later this week as well, related to the specific impact we would see for SAPT-funded providers and SAPT-funded programs around Ohio. So I would hope that by close of business Friday, we will have that available on our website. And when that's published, we will probably do a news now or something so folks are aware to go out and look for that. Okay. Well, I appreciate your time this morning, and I hope you have a great day. Thanks.